ladies. Okay, just let a few more ladies join us and then we'll start today's talk. I'm sorry that we're a few minutes late today, but I just wanted to make sure that everything was okay before we came online. Okay. Okay, so sorry again for last week's talk. Hi Dashi. Okay, so sorry about last week's talk. Okay, we really had some technical errors last week. Hopefully today everything's going to be okay. We are in the midst of rescheduling last week's talk with Dr. Leong from Alpha. Okay, hopefully we can get it in this month. If we can't get it in this month, we'll get it in next month. Okay, so don't worry about that. Okay, so today's talk is with Dr. Sai Daneshman. Okay, he's from the San Diego Fertility Center. We had him in with us a few weeks ago with Dr. Sandy Chuan, where we went through the topic of IVF in the US, okay? But today we decided to bring Dr. Daneshman back because Dr. Daneshman has been involved in a lot of research and publications in the US, and therefore we thought that he'd be one of the best people to answer our questions, okay? So before we start today's session, as we say, as per usual, even though we have a professional online today with us giving us advice, everyone's situation is unique. Therefore, please do seek the advice of your own doctor before you proceed with any of the advice given. Okay, so with that, let's invite Dr. Chuan with us.
Hello, can you hear me?
Yes, can you hear me?
I can hear you, yes. I'm just heading to my office, so good evening.
Oh, so it's only 5:30 in the morning for Dr. Daneshman, and so it's really early your time there. Okay, do you want a few more minutes to get to the office, or you're almost there?
I'm good. I can start. Good evening to all of you.
We'll get a tour as we go along. Okay, so as I was mentioning, you've been involved in a lot of research and publications over the years, okay? And so we thought that you'd be the best person to answer various questions for us today.
Absolutely, no, with my pleasure.
Okay, so let's get into the first one. Okay, fertility options. Okay, what fertility options does a couple have if they've been trying for a baby, okay, and unable to get pregnant? Okay, so what are the fertility options available?
So it all depends on the diagnosis, because the fertility options that are available can be a gamut from intrauterine insemination to surgery. Actually, let me turn on the lights here. So good.
All good.
All good now.
Fantastic.
Terrific. So it really depends on the type of diagnosis, because fertility options can include in vitro fertilization. It can include intrauterine insemination. Sometimes it just includes a medication to make someone ovulate. For example, there are patients who have very high prolactin levels, and those prolactin.
Oops. Okay, let's just. Okay, you're back. We're good.
I'm back, yes. I'm trying to adjust this a little bit. My apologies.
No worries.
So many options, sometimes it includes surgery as well. So, for example, surgical procedures of the uterus, surgical procedures of the fallopian tubes can sometimes enhance fertility. So it really depends on diagnosis.
Okay. So just now, you said, okay, so there's some tests, obviously, that couples should do. What are the vital tests that you recommend a couple doing if they haven't done any tests at all? So what kind of tests would you recommend?
Absolutely. So there are 4 major tests that we recommend. So the first one is the egg quality and egg quantity test. That's done with a hormone called anti-Müllerian hormone. 1 or 2 days.
AMH. Is that AMH?
AMH, exactly right. That's a sort of a marker for the quantity of eggs in the ovaries. Then we want to get an assessment of the quality of the eggs, because quantity is not the only important factor. quality is really the most important factor. So there's a hormone called the cycle day 3 FSH and estradiol, which is done 1 or 2 days after the full flow period. That'll tell us more about the quality of the eggs. In fact, that's a hormone test that was developed initially through a series of papers we published back when I was at UCLA during my training. This is, 24, 25 years ago.
Mm-hmm.
Then we want to get an assessment of the uterus. So we perform a test called a sonohistogram, where we inject some fluid into the uterus so we can see the cavity of the uterus. And then the last test is a hysterosalpingogram, which is an X-ray for the fallopian tubes to assess the patency of the fallopian tubes, meaning if the fallopian tubes are open. So those are the 4 main tests by which we can get an assessment. Now, we can't forget about the sperm. So on the male side, we want to do a sperm analysis to assess the sperm parameters and make sure everything's okay on the sperm side.
Okay, and so, just now you said a sonohistogram and the fallopian tube X-ray. These are 2 tests that actually we don't do very often here in Singapore. So we usually definitely do an AMH and an estradiol test. So let's say if somebody goes to a doctor here and the doctor basically doesn't suggest these tests, should we ask the doctor for these tests?
I definitely think that you should suggest that if it's indicated, ask your doctor whether there needs to be an assessment of the fallopian tubes or the uterus. The uterus needs to be assessed every time, whether intrauterine insemination or IUI is performed or IVF, because ultimately the embryo needs to implant in the uterus. Yeah. And the sonohistogram is a very sensitive test to assess whether the uterus has any abnormalities, such as fibroids, polyps, anything that can prevent the embryo from attaching. So think about it as sort of a flower bed where you're trying to grow a seed. If there's a rock there, the seed's not going to grow. That's the same sort of concept in the uterus.
That's very interesting. Okay, just now we mentioned that one of the options that a couple has is an IUI. Okay, what is the difference between a medicated IUI and a SO, a simulated ovulation IUI? What's the difference?
So medicated IUIs, we use medications. It's either oral agents like clomiphene or injectable agents like FSH. And what that does, it stimulates the ovaries to mature and develop anywhere between 1 to 4 eggs. Okay. So what that does is it increases the number of eggs that are produced within the ovaries, therefore enhancing the probability that there's going to be one good quality egg ovulated. Mm-hmm. And the other thing that it does is it increases sort of the targets for the fallopian tubes. The non-medicated IUI or spontaneous IUI is essentially monitoring someone's ovulatory status, meaning that you time the ovulation, the natural ovulation of the patient to insemination. Sometimes if everything else is fine and the only problem is maybe some slight or mild motility problems with the sperm, you can then perform a non-medicated IUI, a spontaneous IUI, where you just take the sperm, you wash it and concentrate it and inject it into the uterus. In other situations in which, let's say, there's a decrease in the quality of eggs or quantity of eggs in the ovaries, or there's a problem with ovulation, then we use sort of ovulation induction medications or medications to not only induce ovulation, but also increase the number of eggs that are produced and ovulated from the ovaries.
Is there any situation where you would recommend one or the other?
Well, it really depends on the diagnosis of the patient. If the only problem is a mild motility problem, then non-medicated IUI could work. In cases where there are more than one, so let's say there's a issue related to the quality and the quantity of eggs in the ovaries, or you have a patient who is over the age of 34 and you're trying to enhance her fertility, then a medicated one would be more indicated. Also in patients who don't have regular menstrual cycles, they have irregular menstrual cycles every 2 months, every 3 months. We have patients ovulate once a year. In those patients, you have to use a medication to induce or stimulate ovulation.
For the medication, there's Clomid and there's Letrozole, right? What is the difference between these 2 medications?
They work in different ways. So, Letrozole and clomiphene work in different ways, and they ultimately work towards inducing ovulation and maturing and developing eggs within the ovaries. So ultimately, the ultimate mechanism of action is the stimulation of the ovaries to mature and develop eggs, and then ultimately the ovulation. Now, with clomiphene and with letrozole, the best way to time the ovulation is to actually use a trigger medication, meaning that once you use clomiphene and letrozole, you can monitor the ovaries and make sure the follicles or eggs are being produced. And then you use an injection as sort of that final trigger shot to induce ovulation. Why the injection? Because the injection times the ovulation very accurately. So then you can time either timed intercourse, or you can do insemination at the same time, or alternatively do insemination.
Interesting. So people who are going through IUI would definitely have this trigger, right?
Well, if they're going through IUI, they definitely would have the trigger because you have to time the IUI. Now, you can give someone clomiphene and letrozole, they can ovulate, but you can't predict the exact timing. With IUI, you want to predict the exact timing of ovulation, and therefore you want to use a trigger shot.
Understood. In terms of session of IVF, would you, is there a number that you'd say, okay, you should go for how many IUIs before you go for an IVF? Or, I mean, what would you monitor basically?
Typically, if someone is not pregnant after 3 cycles of either letrozole or clomiphene IUI, then they really need to have a discussion, a consultation with their doctor to determine whether the next step would be in vitro fertilization. We typically stop at 2 or 3 cycles of treatment with letrozole or IUI, and then we have a discussion, and we do discuss in vitro fertilization as the next option. Why? Because there may be something more insidious going on. Maybe there's a more significant decline in the quality of the eggs. Maybe the sperm is not fertilizing the eggs. So it may require in vitro fertilization a different level of treatment in order to achieve success.
Apart from IUI and IVF, are there any other ways to get pregnant, basically, of like fertility options? Just now you mentioned surgery, right? What kind of surgery would you?
These could be surgery, hysteroscopic surgeries. For example, if a patient has fibroids inside the uterus, we can remove the fibroids, excise the fibroids. If a patient has scarring in the uterus, polyps, large polyps that can prevent the embryo from attaching, then we can perform surgery. There are options, obviously, with patients who have run out of good quality eggs, egg donation, working with an egg donor. And then, of course, if there's serious issues, medical factors, or for many other couples, then working with a surrogate would be another option because they would need the help of a surrogate to carry the pregnancy.
So someone who has undergone surgery doesn't necessarily have to go on to IUI and IVF. They could very well conceive naturally, could they?
Absolutely. If the diagnosis is, for example, a fibroid uterus, or diagnosis of polyp in the uterus, or maybe there's scarring, sometimes laparoscopy could help. For example, if there's some scarring around the fallopian tubes in which it's impeding the ability of the fallopian tubes to pick up the eggs, then through laparoscopic surgery and what we call adhesiolysis, which is essentially getting rid of and excising the scar, sometimes you can enhance fertility and patients can conceive naturally.
Okay. In terms of quality of the egg and quality of the sperm, is the quality of sperm important in an IVF cycle? Because, I mean, as we know, they only pick one sperm, but is the quality actually important?
That's a very good question, Kim. So the quality of the sperm is still important, and the reason for that is because despite our ability to be able to select out the best quality sperm to fertilize the eggs, and we have many protocols, including microfluidics, ICSI, which is an injection of the sperm individually inside eggs. Men who have very severe abnormal morphology sperm, meaning they have very few normal shaped sperm, even among the normal shaped sperm, there could be DNA abnormality, which could potentially impede the ability of the sperm to fertilize the egg normally and to create a normal embryo. Now, we have developed techniques like microfluidics in order to enhance DNA integrity of the sperm, because you don't want just to look under the microscope and pick out the sperm that appear morphologically normal and moving well, inject those inside the egg. We do one further step before that, and that step is something called microfluidics, where we try to select out the best quality sperm based on DNA integrity.
So what's it called again? Microfluid.
Microfluidics or zymote.
Zymote. Okay. Zymote. Interesting. Okay. A lady with endometriosis. Endometriosis in Singapore seems to be getting more and more common. Okay. So let's say a lady basically has done her scans and everything and has found out that she has endo. What can she do to actually improve her fertility?
Depends on how the endometriosis is affecting her fertility, because endometriosis can affect fertility in many different ways.
Okay.
Endometriosis can destroy eggs within the ovaries. Of course, endometriosis is a situation in which every time a patient has a period, the cells in the blood essentially come out as a period, but in some patients they backflow through the fallopian tubes and these cells start implanting in different areas. For example, on the uterus, on the peritoneal cavity, which is the sort of the lining surface of the inside of the abdomen. It can cause scarring around the fallopian tubes. Essentially what happens is your body recognizes these cells as foreign, so mounts an immune response, and in the process of trying to destroy the endometriosis, there's a great deal of inflammation that's created, and that inflammation can cause scarring. That inflammation can destroy eggs in the ovaries, and that inflammation can prevent the sperm from fertilizing an egg. So endometriosis has many different effects. And essentially with someone who has endometriosis, we have to determine which one of these effects is the major effect and then address that. For example, if endometriosis has caused a significant decline in the quality of the eggs, in vitro fertilization is the best treatment. If it's caused scarring in and around the fallopian tubes to the point where surgical options are not conducive to enhancing fertility, then again, in vitro fertilization is the option. So it all depends on the way in which endometriosis has affected fertility. In the majority of instances with significant endometriosis, IVF tends to be the best option.
Do they need to clear it up before they go for IVF, or can they just basically, even with it, they can still do IVF?
That's a great question. You don't need to clear out endometriosis before you do in vitro fertilization. In fact, there have been studies that have been published looking at the beneficial effects of surgery. And in the majority of instances, surgery has sort of minimal positive impact on fertility. Really what you need to do is address the issues related to endometriosis. The problem with endometriosis is that even if you surgically treat and laser and destroy all the endometriosis, it has a tendency to come back at a rate of somewhere around 20% per year. So you're going to have a recurrence of endometriosis even if you laser it. The other issue is there are many endometriosis lesions that are microscopic and not visible to the eye. So when a surgeon laparoscopically addresses endometriosis, there's still a lot of cells that are not destroyed, and those again can create a great deal of inflammation.
So, but let's say if a lady had endo, and she did get pregnant after an IVF cycle, is there any danger to the baby, or does it have any effect?
Not at all, no danger, because endometriosis really doesn't affect the inside lining or cavity of the uterus. Endometriosis affects the abdominal cavity. It can cause significant amounts of pain with periods with patients, but it has no effect on the pregnancy, no effect on really the ability of the uterus to carry the pregnancy, or for the ability of the embryo to implant.
And then with endo, it could happen at any age. Is that right?
Absolutely. It can happen at any age during the reproductive years when there's ongoing menstrual cycles.
Interesting. How about PCOS? PCOS is another one that is really quite common here in Singapore. I mean, a lady who has been diagnosed, or how does she know she has PCOS?
So polycystic ovary syndrome is a condition in which patients have irregular periods, sometimes signs and symptoms of androgen or testosterone excess. Sometimes they can have a little bit of excessive hair on the face, on the chest, on the upper abdomen. And then when you do an ultrasound on the ovaries, what you see is polycystic ovaries. You see these ovaries with multiple small follicles, multiple small cysts. This is the diagnosis. You have to have 2 out of the 3, either the androgen excess with irregular periods and or polycystic ovaries on ultrasound. So that's, if you have irregular periods and irregular ovulation, there's a good chance you have polycystic ovary syndrome, although you need to see your doctor in order to diagnose it.
Yeah.
Polycystic ovary syndrome is very common. It affects somewhere between 4 to 7% of all reproductive age women. It's one of the most, as you said, Kim, it's one of the most common diagnoses in fertility.
And so if she wanted to get pregnant, basically, what are her options?
Well, typically, if ovulation is the only issue, in other words, if we've gone through the entire diagnostic screen and it seems like irregular periods are the only factor, meaning that the uterus looks fine, the sperm parameters are good, the fallopian tubes are open, and the ovulation, the lack of ovulation is the only issue, then giving a patient medication to induce ovulation typically is the first line of treatment.
Okay. In terms of a lady undergoing IVF, okay, at what age would you basically tell her, okay, let's not use your eggs anymore? Is there a specific age? Or basically, would you say, okay, carry on as long as you have eggs?
It depends on the sort of the hormonal parameters, because when you look at the FSH level on cycle day 3, once the FSH gets above 14, 15, the odds of pregnancy success with IVF start to decrease dramatically. By 40 years of age, about 50% of women have run out of good quality eggs. By 42, that number is close to about 80 to 90%. And by 44, the odds of pregnancy with IVF really, really have diminished. It's less than, sometimes less than 1%. So in a patient up to 44 years of age, there has to be a very frank discussion about the odds of success with in vitro fertilization based on hormonal parameters. In other words, based on the AMH, the anti-Müllerian hormone we talked about, based on FSH and estradiol. And based on that particular diagnosis and diagnostic measures, really a frank discussion to be had about what are the odds of success with fertilization. And for some patients who are in their 40s, where the FSH is very high, in particular, if it's above 15, the odds of success with IVF are going to be very low, and really egg donation would be the best way to achieve the pregnancy.
So basically, a couple should discuss this with their doctors, and they should know the odds before they proceed with IVF.
Absolutely. Before you proceed with in vitro fertilization, there has to be a very good discussion with your doctor about what the approach is, what's the medication protocol, and what are the odds of success? What are the expectations? And I think this is something that I do with all my patients before we start the IVF cycle, is we have a good discussion about what are the different steps in vitro fertilization? What are some of the side effects? How is the patient going to feel? How is she going to be supported? The couple is going to be supported throughout the cycle of IVF. And what are our expectations for success?
We have a lot. Okay, I realize that a lot of ladies, when they choose their IVF center, they usually ask them, what is your center's success rates? Should they base their choices on the clinic success rates, or basically their age, percentage?
I mean, there's always should be some research in regards to your IVF center, in regards to their background, participation research, their reputation. You can certainly discuss the clinic's own pregnancy rates with a doctor. That's an important parameter. Their experience, for example, in IVF, how many IVF cycles they perform every year. Do they have a great deal of experience in patients with decreased ovarian reserve, patients in their 40s? So I think those are all good discussions. Really doing some due diligence before choosing your IVF doctor is a good idea.
Okay, we've had somebody ask a question with regards to PCOS again. Does PCOS definitely mean insulin resistance?
No, it doesn't. It doesn't always mean insulin resistance, although polycystic ovary syndrome is associated in many patients with insulin resistance. Meaning that some patients with polycystic ovary syndrome do have a higher risk of having diabetes, a higher risk of having gestational diabetes during pregnancy. But insulin resistance is a specific diagnosis that's not always associated with PCOS. You have to do further testing in order to find out if a patient has polycystic ovary syndrome, and in addition to that, insulin resistance.
Will reducing carbs help in any way, or basically we don't know?
It certainly does. Having a diet that's lower in carbohydrates and higher in protein and exercise will reduce the incidence of insulin resistance, because insulin does play a role in the of polycystic ovary syndrome? So yes, it does. We have many patients, for example, with a combination of a decrease in carbohydrates in their diet and exercise, and at some point weight loss, do start resuming regular periods. So that's something definitely that we talk about in terms of nutrition and exercise with patients with PCOS.
Understand. Just now we touched on endometriosis. How about adenomyosis? Basically, yeah. What is that? Is it similar to endo?
So adenomyosis is something different than endometriosis. Adenomyosis is a situation in which the uterus is affected. Adenomyosis means that the inner lining of the uterus sometimes invades into the muscle layer of the uterus. And that creates a situation in which there could be pain with periods, there could be infertility. It has a very specific pattern on ultrasound. When you look at the uterus, adenomyosis is associated with many fertility factors, including miscarriages, implantation failures, infertility, pain around the time of the periods. It's essentially diagnosed usually via ultrasound. Okay. And again, a discussion needs to be had with the fertility doctor in order to find out, okay, how is adenomyosis affecting my fertility? In many instances, adenomyosis doesn't have an effect on fertility or someone's menstrual cycles in terms of pain or regularity, but in many instances it does. So if you have a patient, for example, that suffers from infertility or miscarriages or implantation failures with the embryo, and you've diagnosed adenomyosis, there certainly could be a correlation.
Would it affect IVF success rates?
It certainly can affect IVF success rates. And therein lies the issue related to implantation failure, meaning that when we transfer a good quality chromosomally normal embryo, sometimes the embryo doesn't attach, and sometimes that could be secondary to adenomyosis. Unfortunately, there's not a good treatment for adenomyosis because what happens is that you have this sort of invasion of the inner cell layers of the uterus into the muscle layer, and there's nothing that we can do to reverse that. So sometimes patients with adenomyosis, if they have recurrent implantation failure, where the embryo is not implanting, IVF is not successful, in those particular cases, sometimes we have to seek the help of a surrogate.
In terms, okay, we've had a lot of a few doctors. I mean, we had a few ladies who had adenomyosis, and the doctor suggested Lupron. Basically, is that a suitable? I mean, is that a suitable medication?
Lupron and Letrozole have been used sometimes in the treatment of adenomyosis or endometriosis in terms of implantation with some success. So I would say that you definitely discuss that with your doctor, especially if you have patients with severe endometriosis where the IVF has not worked and embryos have been implanted and hasn't been successful. There's some situations in which perhaps adenomyosis, endometriosis may be at play, and sometimes Lupron, Letrozole, other medications may be helpful. Again, something to discuss with your fertility doctor if you have a situation where you've done IVF and you haven't been successful.
And then just now you mentioned recurrent miscarriages. What would you suggest for a couple who basically they can get pregnant, however, they keep facing recurrent miscarriages?
So recurrent miscarriages or recurrent pregnancy loss is a diagnosis that requires a significant workup. That workup includes sperm quality analysis, egg quality analysis, because when you look at recurrent miscarriage, the most common reason is aneuploidy of the embryo, meaning chromosomal abnormality of the embryo, which is related to the quality of the egg. As the quality of the egg starts to decrease, the ability of the egg to align the chromosomes properly diminishes, so you have a higher number of abnormal chromosome embryos, and those lead to recurrent miscarriages. So essentially, there's a significant workup that's done with recurrent pregnancy loss, including egg quality analysis, sperm analysis, analysis of the uterus, analysis of clotting factors, what we call thrombophilia factors, immunological factors such as lupus anticoagulant, anticorrelipin antibody. We want to get a karyotype, make sure patients don't have translocations or breaks in their chromosomes. So there has to be a full workup when patients suffer from recurrent miscarriages.
So how many miscarriages would the couple have before they should go? 2?
2, absolutely. In the old days, we used to wait until 3, but really the new thinking is, why have the patient suffer another miscarriage? Once the patient had 2 consecutive pregnancy losses, especially first or second trimester, a workup is warranted.
Okay. In terms of a failed transfer, okay, or let's say a miscarriage, when should a woman wait to transfer again? Should they transfer the following month, or should they wait longer?
All depends on when the uterus gets back to normal. So in the case of a miscarriage, you have to wait until the HCG hormone levels have resolved and make sure that the patient had at least 1 normal period before you start the preparation of the uterus again.
So that's a miscarriage. How about a failed transfer? So no pregnancy at all.
If there's no pregnancy at all, you can go ahead with the transfer in the next month. So, because what ends up happening is once you stop your medication, you have a period and the hormone levels come back to normal. The uterus is now ready again for another potential implantation.
So there's no research that says you should wait a few months before you transfer?
Not at all. Just in case of miscarriage or any surgical procedures of the uterus, then sometimes you have to wait a certain number of months before, and that's just so that the HCG pregnancy hormone levels resolve, and also making sure that the uterus is back to normal before you start the preparations again.
Is there any truth in evidence that shows, do you know, a lot of ladies say that often you're more fertile after a miscarriage. Is there any truth in that?
That's a myth. There's no really truth in being more fertile after a miscarriage. I think that's just a myth and that just means that some patients do experience a healthy pregnancy after a miscarriage. But overall, we can't generalize and say there's improved fertility after a miscarriage.
Understood. Okay, somebody asked, does hydrosalpinx affect implantation? Is surgery the only way to get pregnant for this case?
So hydrosalpinges essentially means fluid in the fallopian tube. So sometimes when fallopian tubes have scarring, there's fluid that collects in the fallopian tubes. There's some evidence that if the fluid is significant, that it can be seen on ultrasound, perhaps at the time of embryo transfer, some of that fluid can backflow into the fallopian tube and prevent implantation. The studies on that are not convincing. When you look at some of the studies that have been done, that we've done ourselves, patients with hydrosalpinges have very, very high rates of implantation, very high rates of success with IVF. So again, it's a discussion to be had with your fertility doctor. I would say that if an embryo is transferred that is very good quality, chromosomally normal, and there is no implantation, and the patient happens to have a significant hydrosalpinx that can be visualized on ultrasound, then yes, maybe there's some thought to removing the hydrosalpinges before the next embryo transfer.
In terms of fluid, just how you mentioned, so hydrosalpinx is fluid in the fallopian tubes. How about fluid in the uterus? We've had a few ladies recently who have basically told us that during the transfer, prior to the transfer, they have found fluid in their uterus. And they have never had a child before, so basically nothing to do with C-section, scar defect, or anything. Basically, how does that happen, and is there any explanation for that?
So sometimes that could be as a result of situations like adenomyosis. It could be situations where the uterus itself is not creating a normal endometrial lining. It happens with some patients who've had a history of C-sections, who have something called the isthmocele. Yeah. It can happen with patients who've had uterine surgery, whether it's been a DNC, a curettage. And in some patients, it happens because the stem cells of the uterus are not capable of producing an adequate lining of the uterus. A hysteroscopy could be a first-line assessment, meaning placing a camera inside the uterus, taking a look and see if there's any pockets of fluid that are inside the uterus. Are there areas of scarring? Are there any areas that we can visualize to see where the fluid is coming from? Yeah. And then sometimes a natural cycle would be preferred versus a medicated cycle. In other words, when you're preparing the uterus, using a patient's own hormone levels instead of using medication. Sometimes medications such as estrogen pills, patches, can increase fluid production. So it's a complex problem that requires complex thought and approach.
Okay, but there are ways to basically solve it.
Yeah. In majority of instances, yes, but there are unfortunately some patients where there's persistent fluid despite everything that we do, and in those patients, we seek the help of a surgeon.
Understood. Somebody asked, how come chromosome abnormal eggs, how come they can implant?
Because the ability of an embryo to implant has to do with not only just the chromosomal normality, but it has to do with the cells that the embryo has. So the trophectoderm cells of the embryo, for example, are responsible for invading into the wall of the uterus and creating a pregnancy. Sometimes the trophectoderm cells are able to do that despite there being a chromosome abnormal embryo. Therein lies the reason for many miscarriages, is that a pregnancy occurs, but unfortunately the embryo is chromosomally abnormal. 99% of chromosomally abnormal embryos will either miscarry in the first trimester or they won't implant at all. But there are those that can make it beyond 10 weeks of pregnancy and are diagnosed later on with an amniocentesis or blood test and not basic neonatal test in 10 weeks.
In terms of, ectopic pregnancies is also something that seems a bit common these days. Is there any reason why it occurs?
So typically ectopic pregnancies occur as a result of there being scarring in the uterus. So what happens is the embryo makes its way, so when the egg fertilizes the sperm in the fallopian tube, in the distal side of the fallopian tube, that embryo travels back into the uterus on its travel, which takes about 3 days. Mm-hmm. If there's scarring in the fallopian tubes, the embryo can get stuck. Almost think about a sort of a cobweb that essentially makes the embryo stuck within the fallopian tube, and then the embryo essentially implants in the fallopian tube and grows into an ectopic pregnancy. So most ectopic pregnancies are as a result of scarring in the fallopian tubes. In vitro fertilization is typically the best treatment. And again, we just have to make sure that when in vitro fertilization is done, the embryo is transferred in a specific area within the uterus to minimize the chance of ectopic pregnancy.
So basically, where they put the egg, that's usually where it stays?
Well, where the embryo is placed, typically that's where it stays in terms of, yes.
Okay. What should be done basically after an ectopic pregnancy? Can they, so let's say there's a lady who basically had an ectopic, what should be done after?
Well, if they've had an ectopic that's been resolved and been treated, then really there has to be an assessment of the fallopian tubes. If it looks like there is an issue related to fallopian tubes, then in vitro fertilization is the best option. And a discussion has to be had with the patient that if you've had one ectopic pregnancy, there's a high risk of having another one. So maybe we want to proceed with in vitro fertilization to avoid that.
So some ladies, obviously, they also get their tubes removed. Basically, after they get tubes removed, some ladies are quite confused. Can they still get pregnant?
If the tubes are removed, no, they cannot get pregnant.
Not naturally, but through IVF.
But in vitro fertilization, absolutely. Because in vitro fertilization, we don't need the fallopian tubes to be functional or to be present.
Okay. Men, okay, sperm DNA fragmentation. Is doing a DNA fragmentation test important? And basically, what can we help with if let's say they had bad results?
It's important sometimes in some research protocols. Sperm DNA fragmentation was originally not only discovered, but originally used as a way to determine the need for ICSI, intracytoplasmic sperm injection. Because many clinics, as a standard, perform ICSI, DNA fragmentation have become less important. Now, there are men who have severe sperm abnormalities and severe abnormalities with DNA fragmentation. Sometimes you place them on antioxidants, on medications to improve the quality of the sperm. Sometimes doing a DNA fragmentation assay before and after the treatment would be helpful to assess whether there's been some improvement in the quality of the DNA of the sperm. But overall, as a routine workup for men with for sperm analysis, DNA fragmentation assay is not needed unless we see some severe abnormalities with the sperm, especially morphology analysis.
Is there anything they can do to basically increase the sperm quality?
There are some reports showing that some antioxidants can help with sperm quality. There are some reports out of the UK, for example, Dr. Homer's lab that show that oxygen radicals sometimes be present in men with abnormal sperm morphology, and that's what's causing some abnormal sperm morphology. So therefore, using antioxidants in men, certainly some habits like smoking can cause significant abnormalities or lifestyle factors, things like obesity, diabetes, poor nutrition, smoking, excessive drinking. All of those factors can really have an effect on sperm DNA quality and sperm morphology. So again, all of that has to be addressed when we speak to men.
In terms of egg quality, let's say there's a lady, basically healthy lifestyle, everything healthy, but really bad egg quality. What can she do to basically improve on this?
We have specific protocols in IVF that can address decreased ovarian reserve and decreased egg quality. They're not always successful, but we can certainly use based on research parameters and papers we publish. There are specific protocols that we can use. If one protocol doesn't work in IVF, it doesn't mean that there are no more good quality eggs in the ovaries. We can use other protocols that we've had success with. Sometimes despite different protocols, despite our best efforts, working with an egg donor becomes the best option in terms of success.
Understood. In terms of implantation, is there any way we can actually improve the chances of implantation?
Well, making sure the uterus is receptive. So endometrial receptivity has been a sort of a subject of my research and publications over many years. So we have to make sure the uterus is receptive, synchronized with the embryo at the time of implantation. That requires medications, ultrasound monitoring, blood monitoring. So we have to make sure that that we're transferring the embryo in the most receptive phase of the endometrium.
In terms of lining during the transfer, can it be too thick, or basically is there a certain thickness?
Absolutely, and we should discover that before we even move forward with the transfer. So before we start the progesterone injection, we assess the lining of the uterus, and sometimes the lining can't be thick. And just last week, I canceled the embryo transfer because the lining was too thick, and I felt that it was almost like a hyperplastic endometrial lining, and that's not going to be conducive to implantation.
Is there basically usually how many thickness would you suggest is the best to do a transfer?
So typically, the range that we want to see is somewhere between sort of 7 to 13, 7 to 14 meters in terms of thickness. That's the range. If it gets much thicker, 14 millimeters in thickness, then some thought should be made to canceling the transfer and maybe using lesser estrogen, using a different protocol, using a natural cycle in order to achieve success.
So there are ways basically to get around it.
Absolutely.
So, when a lady goes through an IVF cycle, there's so many different types of medication: Gonal, Menopur, Pergoveris, Sizin, Intralipid. Basically, is there a difference between each medication? And why do we have two different medications at a time?
There are different types of medications because they provide different types of hormones. For example, some medications like Gonal-F and Folistem provide more of the FSH activity, and then medications like Menopur provide the LH activity. So what we're trying to do is we're trying to mimic what happens naturally in the body. What are the hormones that are secreted by the pituitary that then stimulate the ovary and develop eggs? So we're trying to mimic that balance of hormones that are created or stimulated by the pituitary gland in the brain that cause the maturation of the egg. We're trying to mimic those, and therefore there are different types of medication that are used in IVF.
In terms of Sizin, that's a human growth hormone. Okay, who would you recommend that to?
Well, the studies are sort of controversial on Sizin.
Okay.
There are no good randomized control studies to show that human growth hormone really has a major positive impact on the outcome of IVF. Sometimes in patients with decreased ovarian reserve, Sizin is used to enhance the number and the quality of the eggs in the ovaries, but the studies are still really not convincing. It is one of the sort of the options, one of the medications in our armamentarium that we use when the other medications don't work, but it's not a first-line treatment for IVF.
Okay, so ladies basically shouldn't worry too much if their doctor doesn't prescribe them with Sizin.
Absolutely, absolutely. If their doctor doesn't, then they have some familiarity with the research and publications that really no good randomized controlled trials on Sizin.
Understood. In terms of dosages of medication, can there be too high a dosage? Or, is it, if you have a low AMH, would you need a higher dosage of medication? Is that how it works?
Sometimes you do, but AMH is only one factor. So The medication protocol dosage is based on a patient's age, her height, her weight, essentially her body mass index, her FSH levels, the number of immature follicles in the ovaries. So there are multiple factors. It's not just one factor. There's about 6 or 7 factors we have to address and analyze before we come up with a dosage. For example, in a patient who is thin, using more medications doesn't necessarily do anything in terms of enhancing the success of IVF. So it really has to be based on a very thoughtful measure of all of these parameters to come up with not only the dosage of medication, but the type of medication as well.
Okay, this is really important because we have a lot of chats where the ladies go, oh, why is yours higher than mine? Oh, I should ask for more, and things like that. So, okay, right. This is something that is quite important.
And that's one of the one of the recommendations I make to patients is that don't make comparisons between sort of your IVF cycle and a friend's or someone else's. Every situation is different. Your physiology, your body is going to be different than someone else. Your diagnosis is different. The approach of the fertility doctor may be different. And that doesn't mean it's the wrong approach. It may be a different approach. So making sort of those sort of head-to-head comparisons is not always a good idea.
Yeah, and it gives you more stress as well.
Exactly right. Exactly right.
In terms of OHSS, okay, is it something that can be reframed?
Absolutely. We actually wrote a series of papers and published many papers on the prevention of OHSS. We use a different type of medication protocol for the final trigger mechanism, and we do that in patients who we feel are at high risk for OHSS. Patients who produce a significant number of eggs, that have very high estrogen levels. So yes, absolutely, it can be prevented. Your doctor has to be familiar with the latest studies on prevention of OHSS, and that's something that I think many fertility doctors are aware of and can adjust the IVF trigger protocol to prevent OHSS.
So basically, a main point is basically if a lady has a lot of eggs, that is something that she should be cautious about.
Absolutely, yes.
Endo scratch. What is an endo scratch?
An endo scratch is, there have been some studies that show that when you go in patients with implantation or infertility where the embryo is not implanted, that perturbing the lining of the uterus, causing a little scratch almost in the lining, can somehow stimulate new cell production, and that may help with implantation. There was a recent study that was done. It was a meta-analysis, meaning it looked at many different studies. And that particular study actually showed that the endo scratch is not very useful. It actually showed that in some patients with the scratch, there was a lower rate of implantation. So again, discuss that with your doctor. At least the latest research that we looked at back in 2019 was a meta-analysis, which is an analysis of multiple different papers. That didn't show any benefit to an endo scratch.
So, okay, so let's say if the doctor did suggest an endo scratch, is there a time limit that they would have to do the transfer after an endo scratch?
Typically, the month after you perform the transfer.
So let's say if that transfer failed, would they have to go for an endo scratch the following month, or?
I don't recommend the endo scratch based on the paper
in the first place
published. So I wouldn't do it from the very beginning.
Understood.
Yeah.
Okay. Grading of blastocysts. So, do you know like different grades, 4AA, 4BC? Everybody gets really confused about that. In regards to the size, ICM and is it trophotoderm cell?
So there are two types of cells, and when you look at the cells, this is sort of a blastocyst right here.
Yeah.
And what you have with this blastocyst is you have two types of cells that we grade. This is the inner cell mass, the group of cells that give rise to the fetus. And these are all the trophectoderm cells that give rise to the placenta and gestational sac. So we grade these group of cells based on objective criteria. In fact, we published many papers on the grading of the inner cell mass and the grading of the trophectoderm as well. So you typically have grades of A, B, or C for these group of cells, which give rise to fetus, and these cells which give rise to placenta and gestational sac.
Is there a big difference in, let's say, if you had a 4AA or a 4AB?
There is.
Can they still implant?
Typically, a 4AA should have about a 80-81% chance of pregnancy. if you have a chromosomal normal 4AA. So there are significant differences between a 4AA and a 4AB. And again, we always have a good discussion with our patients in regards to the quality of the embryos, the assessments, and the grading before we move forward and select the embryo for treatment.
With a 4AA embryo, can there still be chromosomal abnormalities in a 4AA?
That's a great question, Kim. Absolutely. We can still see now the majority of 4AAs are going to be chromosomal normal. There is a correlation between morphology and chromosomal normality, but you can have embryos that are AA in quality and unfortunately chromosomally abnormal. And one of our patients, I think, had a question just during our session here. That yes, absolutely, you can have a great quality embryo that looks great on the microscope. It will be chromosomally abnormal.
In terms of the grade, would you suggest to transfer better grade embryos first?
Yes, absolutely. We always want to move forward with the best quality embryo to get the patient pregnant as fast as possible. You know, we want to get our patients pregnant as soon as possible. So transferring the best grade is the best idea. I can take one other question because I have to go to egg retrieval and just
no problem. Okay, one last question. Basically, is there a difference in transferring one embryo or two embryos?
There is obviously that increased chance of a twin pregnancy with two. So and twins have a higher rate of complications like premature birth and gestational diabetes, high blood pressure. So definitely an important discussion to have with your fertility doctor whether to transfer one or two embryos.
All right, no problem. Thank you so much for your time.
Absolutely.
And
my apologies. I have to go
it's
to
fine.
at 6:30 this morning, but I look forward to reconnecting again and addressing all of the questions that your patients have.
No problem. We hope that everything goes smooth for you today.
Thank you so much, Jen.
Thank you everybody for tonight, and then we'll
Bye,
see you
everyone.
guys soon.
Thank you. Bye-bye.